symptoms or any bowel symptoms might tell you the difference between bleeding that is noted at the vulva or thought to be from the vagina from bleeding from other sources. Also, a careful examination of the external urethral meatus, in which you might find that there is a urethral caruncle, and the lady might be mistaking bleeding from the urethral caruncle for vaginal bleeding. Also, you might find that there is hemorrhoids or a rectal mass. Some simple investigations may also help you, such as looking for fecal occult blood and doing a urine microscopy. How important is heavy menstrual period? It's quite a common problem, and it tends to increase with age. The peak age is said to be between 30 and 50 years, so in the fourth and fifth decade of life. In the UK, about 5% of women will consult their GP for heavy menstrual period every year. And in the United States, it's estimated that anywhere between 20 and 25% of women have heavy menstrual periods. The prevalence in Kuwait is unfortunately unknown, and this might interest some of you to go ahead and try to do a study in order to estimate the prevalence of heavy menstrual bleeding in Kuwait. There is a major impact on the quality of life for patients who suffer from heavy menstrual period. Also, it affects their productivity, and it increases the utilization of healthcare services. Also, in circumstances, there is concern about malignancy from the genital tract, either from the endometrium or from the cervix. Iron deficiency anemia develops in up to 2/3 of these women. Most of them, however, can be managed on an outpatient basis. Occasionally, or I would even say rarely, emergency medical care is required for those that have really heavy bleeding. In the UK, it's estimated that heavy menstrual periods account for about 1/4 of all gynecological surgical procedures. And about 20% of women in the UK before the age of 60 will have a hysterectomy for heavy menstrual bleed. Unfortunately, you see that about 40% of them will have a normal uterus, and that means that there is misutilization of this procedure of the hysterectomy where heavy menstrual periods are concerned. What are the causes of heavy menstrual periods? In 2011, FIGO came up with the acronym PALM and COIN. And the PALM is supposed to remind you of the structural abnormalities that are associated with heavy menstrual periods, such as uterine leiomyomas, endometrial polyps, adenomyosis, which is the presence of endometrial tissue in the muscle of the uterus, and miscellaneous causes such as patients with cesarean scars and AV malformations. And with the increasing rate of cesarean section among our deliveries, we're going to see more and more of patients with previous scars having heavy and abnormal uterine bleeding. AV malformations are a rare cause of heavy menstrual periods. These are usually associated with post-interventions such as DNC, and you see that the patient comes back with a recurrence of bleeding that is heavier and heavier. This is usually a source of torrential bleeding. The COIN is, again, supposed to remind you of the functional causes of heavy menstrual periods. The chief one is ovulatory dysfunction, coagulation disorders, iatrogenic causes such as patients who are on anticoagulants or hormonal contraceptives, or patients on an IUCD, and it's usually the copper IUCD that's associated with heavy bleeding. Neoplasms and the endometrium in the uterus or in the cervix may be a cause of heavy menstrual bleeding, and then infections and inflammations such as chronic endometritis or pelvic inflammatory disease. Also, disorders of local endometrial hemostasis are another cause. There are many causes of anovulation, and I don't think there's enough time to reiterate all of them, but the common causes are things like high prolactin, hypothyroidism, polycystic ovarian disease, and then some systemic diseases such as acute liver failure and chronic renal failure may also contribute to the causation of anovulation. So how do we manage heavy menstrual period? First, confirm the diagnosis. Remember the age. Remember to exclude pregnancy. And remember to exclude extrauterine causes by an initial physical examination. Your initial assessment also should include an assessment of the hemodynamic stability of the patient. So in the rare case that you will have a hemodynamically unstable patient, you're going to start with resuscitation and IV fluids, and you may need even to arrange for blood products. You're going to need to do a baseline CBC and a coagulation profile. And you must always exclude pregnancy, especially in the hemodynamically unstable patient. You have to think of stopping the bleeding somehow and then referring the patient. To stop heavy menstrual periods, you have a number of choices. You can either use hormones, which are usually intravenous or oral estrogens, or you may use mechanical methods, such as packing the uterus either with gauze or with a Foley catheter, sort of tamponading of the bleeding. Or you may think of doing a DNC to curette the endometrium and stop the bleeding if there are other measures do not help you. Or you may think of doing interventional radiology, and the uterine artery embolization, in this case, you will do it if you think that the patient has an AV malformation. If the patient is hemodynamically stable, then your first thing is to rule out a pregnancy and to do a CBC. You want to see if the patient is anemic or not, because that's going to guide you whether you can continue with outpatient management, or if the patient is so anemic that she might need a blood transfusion, you may need to admit her. Also, you need to rule out a primary medical condition, because treating that medical condition is going to be the management for the heavy menstrual period in that case. And if that is outside of the realm of your specialty, then you're going to refer the patient to a gynecologist. So what are the things that determine how we manage these patients? Of course, what is the cause? That's going to be the primary determinant of our management. The severity of the bleeding is another thing that we talked about. Whether the patient has associated symptoms and issues that might guide you in one direction rather than the other, where you're going to use medical therapy or surgical intervention. Whether the patient has any contraceptive needs, medical comorbidities that might be contraindications to some of the hormones that you want to use, and also patient's preference. What does the patient prefer? Does she prefer to have a medical or surgical intervention? Does she want short-term relief or long-term therapy? So empirical treatment is never a good idea, because unless you know what the cause, you might be missing either a sinister cause, such as some kind of underlying malignancy or neoplasm, or you might be missing a cause, the correction of which is going to improve the health of the patient as well as get rid of the heavy menstrual period. Also, always give a thought to either treating or preventing iron deficiency anemia, because as we said, about 2/3 of these patients will at some point develop iron deficiency anemia. So your initial workup in the office is going to include a CBC, also a coagulation profile. We used to think that only post-menarchal girls present with heavy menstrual bleeding due to coagulation defects, but newer studies say that about 15 to 25% of ladies in the reproductive age might be presenting with heavy menstrual periods for the first time due to an underlying coagulation defect. When you're doing the examination, you're going to collect a cervical smear, unless you see a cervical lesion, in which case you would collect a biopsy. Also, it's a good practice to try and collect a high vaginal swab and endocervical swab to rule out the PID and the chronic inflammation. And endometrial biopsy is needed either if you want to confirm chronic endometritis or to rule out endometrial hyperplasia without atypia or endometrial cancer. And you need to think of endometrial cancer in patients who have chronic anovulation because of chronic unopposed estrogen, or those who have family history of that puts them at risk for endometrial cancer, such as patients that have family members with endometrial cancer, ovarian cancer, and colon cancer. You're going to need to do an ultrasound scan, and if you think that there is an intracavitary lesion, it's a good idea to do a saline infusion ultrasound, because that's going to show you the polyp, it's going to show you the submucous fibroid that might be otherwise difficult to see. The measurement of endometrial thickness in ladies of reproductive age is not very helpful. The studies that tell you that if it's less than 4 millimeters, you can rule out a cancer, were done for postmenopausal ladies. Again, you might think of doing a hysteroscopy, and if you do a hysteroscopy, it should be better if you plan to treat whatever lesion you find by the hysteroscope at the same time. So plan to do a hysteroscopy and proceed. Workup for anovulation includes looking for the cause, and the common causes, you can find them by doing some simple tests: FSH, LH, estradiol, mid-luteal phase progesterone, TSH, prolactin, and a GTT if you suspect your patient of having PCOS. So as we said, treat the underlying cause, whether it's a medical treatment for endocrine disorders such as PCOS, or antibiotics for chronic endometritis. If it's a structural lesion that is amenable to resection, think of resecting that, such as if you have a polyp, remove it. If it's a submucous fibroid, again, go ahead and remove it. Medical management is the initial approach for patients that don't have structural lesions. And most of the time, you're thinking either of contraceptive pill, combined contraceptive pills, or an IUCD that contains levonorgestrel. You may think of progesterones for patients that have contraindications for estrogen, and I'm not going to dwell on that because I'm sure Dr. Abtesam is going to talk about that in her presentation. For patients that prefer not to have any hormones whatsoever, you can try non-steroidal anti-inflammatory medications, and they do perform better than placebos, but tranexamic acid performs better. And the other advantage of these medications is that they can be taken again only during the cycle. Surgical management is reserved for women who fail or cannot tolerate medical therapy, or those who prefer long-term options. When you're thinking of planning your surgery, think of the patient's future reproductive plan and the risks that she has and the level of the invasiveness of your procedure. So for fibroids, you might think of doing a myomectomy or uterine artery embolization or MRI-guided high-frequency ultrasound ablation. For other conditions, you can think of endometrial ablation or a hysterectomy. So in conclusion, when faced with a woman who is having heavy menstrual bleeding, first, ascertain the hemodynamic stability of the patient. Then ensure that the bleeding is coming from the uterus. Rule out pregnancy and rule out anemia. For the causes, remember the palm and the coin. Treat medical underlying conditions, if any. And finally, refer to the gynecologist to treat structural causes and chronic anovulation. And that's the end of my talk. Thank you.
Good morning. Our next topic will be about contraception for women with medical disorders by Dr. Abtesam Ghadamfar. Dr. Abtesam Ghadamfar is a consultant obstetrician and gynecologist in Al-Adan Hospital. She's also a clinical tutor for undergraduate students and postgraduate residency program.
I will present contraception for women with medical disorders. So, although contraception has been known and recognized from medieval ages by the use of coitus interruptus, withdrawal, obstruction, putting a foreign body, cloth or whatever inside the vagina, but still we are having unintended pregnancies, unwanted unintended pregnancies. In the USA, the prevalence of use of contraception is 77%, and worldwide is 63%. And still we have 3.2 million unintended pregnancies occurring was estimated to occur in USA in 2006. So 3.2 million unintended pregnancies, which will end by termination of pregnancy by abortion. Why do unintended pregnancies occur? Why women choose not to use contraception? A group of pregnancy risk assessment monitoring system interviewed 8,000 women who had a viable pregnancy and did not use birth control. They chose not to use birth control. And the survey result was that 33% thought they could not get pregnant at the time when they had the intercourse. 30% did not mind if they got pregnant. It didn't matter really for them, but when it happened, they chose to terminate the pregnancy. 22% stated that their partner did not want to use a method, and 16% cited side effects with the use of the different methods of contraception, so whether they have started and then discontinued because of the side effects. And 10% thought they or the partner were sterile, so they didn't think that they can get pregnant. And 10% they had a problem accessing the contraceptive or the birth control method. And 18% had other reasons for not using a contraceptive method. So we see that if we go back to this, like around 1/3 of the interviewed women, they had lack of education on the method to be used, the side effects, and the fact that they can get pregnant and they thought they couldn't. So this huge number of unintended pregnancies can cause significant cost besides the risk on the pregnant woman. So in the UK in 2010, the coverage, the cost that was covered by the 218,100 unintended pregnancies was $299,200,000, whatever. So it was a big cost. And in USA, the annual cost is $4.6 billion to manage these unintended pregnancies. So it does cost a lot, while contraception itself, on the long run, is very small cost compared to this. In our setup, in our countries, and then we have to consider several issues when we are thinking about unintended pregnancies or pregnancies which impose risk on the mom. We have legal issues we have to consider, we have religious issues, and we have, so we cannot really resort to termination of the pregnancy. And managing these pregnancies, especially in women who have medical problems, will add cost because of prolonged admission to the hospital, because of added costs of monitoring these pregnancies and monitoring the mother. And many of them will be delivered early, so they have a neonatal admission cost and morbidity associated with preterm babies, with the cost coming with that, associated with that due to investigation and management. So there are factors to consider before recommending a contraceptive method for the mom, which include the efficacy of the method used, the convenience to the woman using it, duration of the action, and reversibility and time to return to fertility as the mom wishes or the woman wishes, effect on uterine bleeding, which Dr. Jihad has touched on. So whether it's going to cause increase in the bleeding or it can help in controlling the bleeding and decreasing the blood loss. Type and frequency of side effects and adverse events, the cost of the contraceptive method, the accessibility to the woman, and protection against sexually transmitted diseases when using barrier methods, and non-contraceptive benefits, which can be gained by using these birth control, and medical conditions, medical contraindications. So mainly the things that we are going to touch is the efficacy, the convenience, type and frequency of side effects and adverse events, and the medical contraindications. Before we start, it is good to remind ourselves about the Pearl Index. It's the number of failure of contraceptive method per 100 women years of exposure. And usually we talk about the actual use Pearl Index or the perfect use Pearl Index. Actual use means that includes all the pregnancies in the study in all months, regardless, meaning even the woman could not be using it in a consistent way, or in a proper way, or a perfect way as advised by the use of the contraceptive. And the perfect use is that includes all pregnancies that resulted from correct and consistent use of the method, and only includes the months or cycles that the method was used correctly and consistently. So this leads us to compare between the actual use and the perfect use failure. And if we go through the methods which are considered to be long-acting and reversible, اللي هو depot and intrauterine device, or the non-reversible, which is the sterilization, both male and female. And you can see that because they are not patient or woman behavior related, so they do not show any difference. Like they do not show any difference in the actual or the correct use. So they are almost the same. While methods, this is not a good, not precursor, not good. But the methods which are dependent on the correct use, they can show a difference, significant difference, where a Pearl index of 2 and can go up to 18, okay? For example, the use of oral contraceptives even, okay? It can vary from less than 1, the patches, and the to 9 with the typical use, which includes missing pills or inappropriate use. The effectiveness of contraceptive method is expressed as both the theoretical perfect use and the actual typical use. However, we have three types of effectiveness. We have the most effective, which applies to methods which are long-acting, whether reversible or non-reversible. And they usually, the failure rate is less than 1 per 100. While the least effective are the ones listed here, like the condom, the female with their male withdrawal, sponge, and spermicides, and they see the range up from 21 to 28. So high failure rate. And in the intermediate comes the pills, injectables, and the diaphragm and ring. So types, I think we all know that, hormonal, whether combined, whether progesterone only, and also IUCD is considered also hormonal. Non-hormonal is the copper IUCD, barrier methods, and then tubal ligation and occlusion, meaning hysteroscopic occlusion of the tubes, and then vasectomy and other methods. Complications, mainly I'm talking now here about complications related to hormonal, mainly the combined oral contraceptive. There was a lot of concern concerning myocardial infarction risk, and actually the healthy woman in the reproductive age without any previous history, it is estimated that it's going to be doubled. But as it is relative risk of MI is actually rare itself, so even double is not really a significant risk that prevents the use of combined oral contraceptive in healthy non-smoker women. But older women who are smokers, it carries a significant risk. Hypertension, a large study was done between nurses, 70,000 nurses in the reproductive age, and we're using oral contraceptive, the combined type, and the relative risk was only 1.8 for women who were using the contraceptive pill. And usually, so it's a small risk, and when they stop the use, the blood pressure goes back to normal. The venous thromboembolism risk was always a concern to women, and every now and then we hear about, don't use this and don't use that because they increase the risk of having a venous thrombosis. The relative risk is only 3.5, which is a small risk, and it is less than the risk during pregnancy. I mean, pregnancy itself causes venous thromboembolism risk. It is really higher than using the oral contraceptive, and the benefits that come from the use of oral contraceptive compared to the risks are better. Now, as a general rule, permanent, non-reversible methods are the best for patients who have completed their family. Pregnancy imposes considerable risk on their well-being or life, and the tubal occlusion, ligation, or vasectomy are the methods of choice. Women with active cancer or who have been treated for cancer within 6 months, they should avoid estrogen, progesterone, contraceptive combined due to the risk of deep venous thrombosis. Women with osteopenia, women with osteopenia or osteoporosis, they should avoid injectable progestogen only contraceptive like the medroxyprogesterone acetate because it has a negative effect on the bone mineralization density. Women who are immunosuppressed, intrauterine contraception is not contraindicated for them. The studies were done and there was no increased risk of having a PID or infection because of the use of IUCDs. Women at risk of breast cancer or recurrence, they are usually are not advised to use combined oral contraception, any hormonal contraception, whether combined or mini pill, but they can use emergency contraception pills. They are not contraindicated and can be used for emergency contraception. And we should avoid estrogen-containing methods in women with high risk for DVT. Now, I am going to go through quickly some medical conditions where which type of contraception is advised and which one is avoided. The reference for that is from the CDC, and it has a site where it's going to state all the medical and non-medical conditions and the recommendation to which type of birth control to be used. And they have divided them into 4 ranges, like from 1 to 4. And 1 is usually where there is no risk associated with the use of this method in this certain condition. 2 is when the theoretical risk is not compared to the benefit that the patient can get from the birth control. 3 is when the theoretical risk a little bit higher than the intended benefit, and 4 is contraindicated use. So let's start by cardiovascular and hypertensive diseases. And the safest method in these patients is the use of intrauterine device, whether copper or levonorgestrel device, اللي هو المارينا. Progestin preparations can be used except injectable because, as we said, medroxyprogesterone acetate has a negative effect on the bone density, and we should avoid estrogen-containing methods due to increased risk of DVT. Patient with diabetes, copper IUCD is the preferred method of use. Hormonal and non-hormonal are also acceptable in diabetes, the ones who do not have any vascular manifestation. But once the patient has nephropathy, retinopathy, or neuropathy, and the diabetes has been there for more than 20 years, hormonal methods are to be avoided. Patients who have history of deep venous thrombosis, they are at higher risk of having patients with high risk. They have more than one risk factor, or patients who do not have a risk factor but they had history of DVT are advised to avoid estrogen-containing methods. Best method is long-acting contraceptive, whether reversible or permanent. Copper IUCD is also preferred for patients who want a temporary contraceptive method, and progestin-only methods are acceptable as the benefits outweigh the theoretical risk. So they can be used also. But best thing is, but they have to remember to avoid estrogen-containing methods. And patients who have thrombogenic mutations like factor V Leiden, prothrombin mutation, protein S, protein C, and antithrombin deficiencies, their best method for them is to use a device. The second option for them would be a progestin-only method, and they should avoid estrogen-containing methods. Systemic lupus erythematosus. There are patients who have higher risk of having osteoporosis. They may be because they are on steroids. They might be on immune suppression. So these patients are a special category of patients. So levonorgestrel IUCDs is a safe and effective option for them. It does not increase thrombosis risk, and it doesn't have a detectable impact on bone density, and it causes a reduction in the menstrual blood loss, which is particularly helpful for patients when they are on anticoagulation. Combined estrogen-progesterone contraceptives are better avoided. However, they may be used in patients with stable low-activity disease and who have negative antiphospholipid antibodies. Progestin-only contraceptives such as the mini pill are a good option for SL patients who do not want to use a device, and they have high disease activity, positive antiphospholipid syndrome, antibodies, and they have other contraindication for the use of estrogen. So they can use the mini pill. And we should avoid dihydroxyprogesterone acetate, as it has an effect on the bone density, and these patients usually sometimes are on steroids, so it is an added risk for decreased bone density. Now, patients who have neurological problems, like patients who have headache, and epileptic patients, the non-migraine headache, all methods are safe for use. The migraine headaches, our best option for them is IUCD, especially the ones who have an oral. Epilepsy patients can use any drug as long as they are not, can use any method of contraception as long as they are not using any medication for control of epilepsy. But once they are using medication like phenytoin and the other groups, they are advised to use IUCD. Patients with breast cancer, with current breast cancer or history of breast cancer, sterilization is a good option when indicated, and it's best for them to use an IUCD. Whether copper, better is copper, but they can use a levonorgestrel IUD to reduce the risk of tamoxifen-induced endometrial changes. Like you have a patient who keeps coming with thickened endometrium, who keeps coming with repeated endometrial polyps. So this is a good option for them. Avoid all other hormonal methods. In inflammatory bowel disease, they can use an IUCD safely, and they should avoid oral or hormonal. The anemic patients, it's better for them to use, avoid IUCD copper, but good for them to use the hormonal IUCD because it can put them in amenorrhea and decreases the blood loss. But they should avoid the regular IUCD because it can cause menorrhagia and heavy blood loss. Conditions in which a progestin-only contraceptive may be desired. We mentioned several of them, so I'm going to skip that for the purpose of time. Women with disability. We often see women who are coming on a wheelchair, and these women have high risk of, because of decreased mobility, they have a high risk of having bone density loss. So we should think of, and they have also increased risk of thrombosis. So an IUD would be hormonal IUD would be a good option for them, as it decreases the bleeding, let them go into amenorrhea, and it's a good option for them. When it is safe to stop using hormonal contraception, well, because the menopause can go from 45 to 55, so around 51 they should consider changing to a non-contraceptive method. And then when they see that they are in menopause, they can stop using all types of contraception. And this is the site, the CDC site. And thank you for listening.
Our third topic for today will be on pregnancy outcome post-bariatric surgery, which will be presented by Dr. Amal Khadr. Actually, this is a pretty recent topic and very interesting topic. Dr. Amal Khadr, she is a specialist in obstetric and gynecology in Farwaniya Hospital, and she has subspecialty in fetal maternal medicine from UK. So welcome, Dr. Amal.
I would like to thank the Kuwait Medical Association organizing committee for inviting me to give this lecture. Okay, so good morning, everybody. Today I will speak about pregnancy and the neonatal outcome after bariatric surgery. The main objectives of my lecture today, I will briefly discuss the maternal and fetal risks in obese women. And then I will briefly touch on the type of bariatric surgery procedures. And then I will talk about the advantages of bariatric surgeries in relation to maternal and fetal outcome. And then I will speak about the management of a pregnancy following bariatric surgery. And then I will end my presentation with the conclusion and the recommendations. Unfortunately, the audience response system is not active. I'll start my lecture with the questions to the audience, and we will answer the questions at the end of my presentation. Maternal obesity is associated with increased risk of all the following except emergency cesarean section, B, induced labor, C, antepartum hemorrhage, D, thromboembolism. Keep this question in your mind. We will answer the questions at the end of the presentation. The second question is pregnancy after bariatric surgery is associated with decreased risk of all the following except preterm labor, preeclampsia, gestational diabetes, fetal macrosomia. Okay. Obesity has become to be dramatically increased worldwide in women of reproductive age, and maternal obesity has become one of the most commonly occurring risk factors in obstetric practice. Obesity in pregnancy is usually defined as BMI of 30 kg meter square or more in the first antenatal consultation. According to the UK Centre for Maternal and Child Inquiries in 2006 to 2008, reported that 47% of mothers who died from direct causes were either overweight or obese. So, in 2013, Rahat Khan and his group summarized the maternal and fetal risks in obese women based on several studies undertook on the, sorry, we missed the table here. Okay, sorry for this. Rahat Khan and his group summarized the fetal and maternal risk in obese women, and they found the risk of maternal diabetes, gestational diabetes, hypertension,